Hi, we're going to continue on and we're going to talk about holistic comfort theory. So one of the main reasons, or I have a couple reasons that we want to talk about it, because one, it's our program's theoretical framework. Her name, the nurse theorist, it's a mid-range theorist, Dr. Catherine Kolkaba. She is the founder. She's still alive. She's in her late 70s, and she's coming to talk to us in our virtual classroom. And I hope she's going to be healthy enough to do it. Before we have her in the classroom, I want to be sure that you have an understanding of why we selected the framework, who she is as a person, and what an amazing, incredible thing that she did. And so we're going to just get you familiar with Dr. Kolkaba. I also want to share that in each face-to-face lecture, in each course, we're going to be doing a comfort activity to embed that theoretical framework throughout your education. And we're also going to be working on cultural competence activities as well. So on with Catherine Kolkaba. So there are many reasons why we looked at all these things. So let me just share a little bit of the process. When I looked at a bunch of different theories to see which one would be suitable as a framework, I considered many. So Dr. Kolkaba, I knew she was still alive and somebody I had followed for a lot of years. And I went to her first. I actually emailed her and asked her for guidance on, what is the process on how we really know if it's the most suitable thing. She led me to Dr. Mickey Goodwin, who's the Dean of Health Sciences at Hopkins, who utilized comfort theory for her dissertation. She used it to underpin an accelerated BSN program and found that when implemented, it was a beautiful thing. It accomplished all of their goals. So let me back up for Dr. Kolkaba for a second. She created comfort theory for her dissertation when she finished her PhD. First of all, who does that? No one does that. I barely survived my dissertation, but she's married to an epistemologist. And probably many of you don't even know what that is. I think it took half my doctoral program to figure out what that is, but it's a way of knowing. She just coincidentally happened to be married to an epistemologist who helped her carve out her theory and look at the concepts and all of those. To create a theory is, I cannot even say, it's just such an incredibly ingrained theoretical, it's just one of the hardest things ever. That's why there just aren't that many theories. Anyway, after talking to all these people, they led me to research. I looked at, the bottom line is, comfort theory was the most suitable for a few reasons. Okay, so actually, I'll back up there for a second. One of the main reasons is comfort theory would help us to accomplish our goals, what we want for our students. And now, sorry, I'll go back to that slide. BSN programs, I'm not sure if you're aware. So my little funny clip says, "No, it's not the baby. My husband is the one who's cranky and cries all night. He just started nursing school." And that is so true. BSN programs are the #1 most stressful program in the country. And knowing that and creating a BSN program for Elizabethtown, I knew that our RN students would be balancing some pretty heavy and competing priorities. I have heard from many, many students in the coming from an associate's or diploma program that their prior learning experiences were incredibly stressful. And that's a main reason why those nurses didn't want to go back to school. And then, of course, you add the demands of nursing school, and we'll just keep going. And then again, the goal of the program was to create an environment where learning is a partnership between the student and faculty, and there's mutual respect and trust. And I have come from institutions where I've worked where it is student versus the faculty versus the student. They say they're student-centered, but they're completely not. And so what I mean by that is you really are student-centered at Elizabethtown. We put you in the center. We create all the things around you. We want to support you and be part of your plan for success. And we want, most importantly, for you to learn in a classroom environment that is free from fear and coercion, because I understand that many students are coming from environments where that was intimidation was the norm, and that's just the way that we learned, and it's not the best way to learn. So let me tell you a little bit about Dr. Kolkaba. She was born on December 28th in 1944. She's now a retired professor, but she's a diploma grad, so she's an RN to BSN grad, just like the program that you're in now, and went all the way through to become a PhD. Again, a very, very tall order for a woman of her time. She is retired as a professor, but she's traveling all over the country with Gene Watson, and they're using a combination of their theories to underpin and cultivate cultural change within these organizations. They're just amazing, just amazing. And then we're going to just stop here for just a second, because I would want you to think about, I'm going to give you this piece of paper, and I want you to think about, what does holistic comfort mean to you? And now I know I'm putting you on the spot, but I'm going to explain what it is. So just think to yourself. So now throughout the rest of the program, we're going to keep revisiting what holistic comfort means to you now. And then we want to see how that's going to be different at graduation. And to really drive this home at graduation, we're going to be doing a comfort quilt. And you're probably like, oh man, Homa, this is too much. But we want to have a tradition in Lancaster County. Quilting is very important to many cultures here. We're going to make it a celebration and a tradition that each cohort will contribute to the quilt. And I'm hoping that we'll find that you had your student experience has been excellent, and I think it's because of comfort theory, hopefully, that it will. The definition of holistic comfort is it's an immediate experience of being strengthened through having the needs for relief, ease, and transcendence met in 4 contexts of the experience. And I'll break all these down for you. In Latin, confortare means to strengthen gently. These are all the foundations that we have as a nurse. And then the conceptual framework is really just a bunch of terms kind of threaded together. And her theory of it is, if my patient is comfortable, and here's the new concept, if I as the nurse am comfortable and my patient is comfortable, then everyone around us is going to be comfortable. And not only are we going to be comfortable, but we're going to share with others about our experience, and we're all going to feel good in the organization of where we are. So all a theoretical proposition is it's a statement that connects the bubbles that we saw in the previous slide of all those concepts. The formal definition is a relational statement that connects the concepts together. And what she believed the propositions were is that the healthcare team unites unmet needs of the patient and family, and then all of these other things below it follow. The nurse and patient work together in concert to craft a plan to meet their needs, and isn't this like the nursing process? They create comfort interventions that are designed and then fully implemented or operationalized. They identify intervening variables to overcome, and we're going to talk about what those could be in a couple slides. And then enhanced comfort is achieved when effective interventions are provided in a caring manner. Historically, our roots, so nursing history, is that one of the primary duties of a nurse at that time, because they couldn't do a lot, is they provided comfort. That was one of their main things. Patient, family, and nurse are motivated when comfort is noticeable and it's enhanced. And then again, we kind of talked about this before. The healthcare facility gains recognition. So not only is everybody happy within the health system, but then it also bubbles outside of the theory as well. And this is like a systems theory where, let me explain, if you've ever had someone in the hospital before, like a loved one, a child, a parent, someone, you notice that the nurse is not the only person that comes into the room to talk to your loved one. It's more than likely you have interactions with environmental health or services. Pharmacists may come in, a physician or provider team, they come in. Our experience is based on all the influences around us as well. That's a systems theory that essentially believes that. And so part of her theory is that she needed to identify, because comfort's kind of this ambiguous term, right? It means something so different to each one of us. And it has a very strong cultural connotation. Some cultures accept it and some do not. The first assumption, so an assumption is just like, in order to think that comfort theory will have an impact, we all have to believe these same 3 concepts in order to think that it will work. And the first one is human beings have holistic responses to complex stimuli. Holistic just means of not just the physical sense of the body, but all senses of the body, spirit, mind, body, everything. From the second part of it, I have a really hard time understanding, and that's complex stimuli. And essentially, that comes from our roots. Before nursing really became its own discipline, we stole all of our research from sociology and psychology. And psychology is where we stole this from. A complex stimuli, I can't exactly explain it, but I can kind of tell you what it is. It is, a psychologist will give you a visual picture and they'll show you a face. face. That's a complex stimuli. If you looked away, you may have a hard time describing what that was. And to compare that to simple stimuli, that would be something like showing you the drawing of a rectangle. But that's really probably as deep as I could explain it because I'm not a psych person. The second assumption is comfort is a desirable holistic outcome that is germane to the discipline of nursing. And all that means is it comes from our roots. It's built on the meta paradigm of nursing, which hopefully you remember that from Florence Nightingale in the course. And the third assumption is human beings strive to meet or have their basic comfort needs met. And that is so absolutely true. And then 3 attributes of comfort. So these are 3 adjectives that Dr. Kolkaba thought that described or comprised comfort. First is relief, which is pretty easy one to get. That's meeting a specific need for a patient. Ease is a state of calm or contentedness. And then transcendence is maybe not a word we use all the time, but essentially it means rising above one's problems or circumstances. And a good way to think about transcendence is, have you ever had a patient in pain? When they're in the midst of that painful episode, they can't think about sometimes anything but the pain. They're focused on it. And you as a nurse, you're focused on it because you're doing everything you can to try to ease their pain. Pain meds, whatever, you're busy. But once that patient finally gets the pain under control, then your life is easier. So you have comfort, patient has comfort, and you have comfort. And that allows that patient to rise to a different level where now they can think about other things like ordering their menu or doing other things. They're able to rise to a new level where they're not in that state of constant pain. And then, of course, these attributes can occur in any one of the contexts, and we're going to talk about what context she was referring, and here they are. The first context is physical, just meaning the body. The second is psychospiritual or emotional, which just means relating to self, a higher being, and meaning. It's whatever it depends to you as a person, your upbringing, all those things. Sociocultural is relational. It could be your social dynamics and cultural circumstances that comprise what comfort means to you. And environmental are just all the external circumstances that can impact your experience. So who determines comfort? Well, it's like pain. It's like the 5th vital sign. The only person who can describe it or say if comfort has been met is the patient. We can't, even if we don't agree with it, if we think, listen, buddy, I just spent 4 hours trying to get you comfortable and you still say you're uncomfortable. Oh, well, I've tried everything. That's not up to us. It's up to the patient. Catherine Kolkaba was so smart that she decided, well, comfort's kind of this ambiguous term. It means something different to each of us. So I'm going to create a tool to decide to help us to show the effectiveness of holistic comfort. I don't know who does that in their dissertation. I didn't do that in my dissertation. I'm still blown away. But she created this taxonomic structure, it's called, where the 4 contexts are down the left-hand side or the y-axis, and across the x-axis are relief, ease, and transcendence. So those are the characteristics that describe comfort. And we're going to apply this in just a minute. So here we are, woo! So now we're going to use this case in point of the stress of a BSN student. I hope this doesn't mean your program now. We're going to talk about maybe what your symptoms are as a BSN student here at eTown. So because of the stress of your homework, you might be anxious. That's a physical context. You might have nausea. You could have a headache. Anxiety causes physical symptoms. Again, we can carry this out. And what's so great about this is that this helps us as nurses be able to use this theory under a lot of different circumstances and apply to different populations. And what I mean is, comfort theory has been carried out in labor and delivery. And don't you think about it, who you want the labor experience to be as comfortable as possible. They use it in the perioperative area. It has been attempted there. Again, another place where, wow, you need people to be comfortable. It just makes perfect sense. And it's been successfully carried out and implemented in all those areas, just to give you an idea. So this is applying a theory to practice. Holy moly, we're doing it. And then additional comfort measures that you may or may not think about. I think a lot of times nurses just do this and they don't actually think about what it is, just second nature to them. And that is like, you could be relief, could be giving a warm blanket to somebody who's shivering and so cold. It could be explaining or to our students that, hey, we're going to move your discussion question that's due. Your initial post is going to be due tomorrow night instead of tonight. It could be transcendence, that you're the coach and you're providing distraction, diversional activities, and you're helping the mom to breathe during the delivery process. It could be the environment where we provide the family a private room to go through the end-of-life experience with soothing, quiet music. It could be sociocultural, where it's important to have the chaplain or pastoral care there. Or we could be following cultural practices as we prepare the patient and family for death. And then it could be physical. I'm just dating myself, but I remember as a brand new nurse wearing a nursing cap out of nursing school, yes, don't be traumatized, that we had these things called comfort rounds at 10 p.m. every night I started out in med-surg on an oncology floor. All the nurses on the one side of the hallway would get together and we would go bed to bed to bed, give a back rub, freshen water, do all the things we needed to kind of tuck a patient in for the night. And of course, we don't do that anymore. We probably couldn't staff anything appropriately, but I do remember that as such a pivotal time and how comfort was really a focus for us at that time. And then factors that may affect a patient's ability to perceive comfort. They just may not be ready for it. And that could be they had a really horrible healthcare experience before. It could be their generation, that they're not going to get all squishy over comfort things. They're going to duke it out and be tough. It could be because of your finances, you don't have money for nurses to care for your loved one or whatever. Finances are a huge factor in feeling supported and comforted. It could be your attitude. It could just be you think comfort is for sissies. I don't know. I can't think of anything else for that. But acceptance of the state of health. And that could be like patient was just diagnosed with something really awful and they're just not in any place where they want to even think past like today. They just can't even think about it. Lack of support system is an incredible burden to families going through especially a life-threatening illness. I found that in my research study, and we can talk about it another time, but it's a huge burden to families. Again, prognosis kind of ties in with the acceptance of state of health. And then your emotional state. And that could come from a cultural thing too. That's just how people in my culture act when X, Y, or Z happens. And then the goal of therapy depends what population we're applying it to. My goal of the theory for all of you is to graduate, that we meet your need, that you'll be able to function at a much higher level than you are now, that you get through the school experience. You may be stressed. We can't reduce all of it, but knowing that you're in a supportive, caring environment, you're in a collaborative partnership with your faculty and the rest of the school, and that you know that no matter how bad things are, that we've got your back and we care about you and we want you to be successful. And then the nursing meta paradigm. This is a sleeper, but go over briefly. So again, I also want to remind you that on March 22nd at 9 a.m., we have a collaboration with King's College. If you can join, it is a synchronous session, and that is Florence Nightingale's school that she established 200 years ago. And these are the fundamental 4 concepts that she believes so strongly, and it's in everything we do. It underpins the entire nursing discipline. And from a nursing perspective, it just means that we're providing comfort needs of the patient addressed through the nursing process. Person is patient, family, community, or institution. So they're all part of patient and family-centered care. Environment is just all the external surrounding and influences of the patient. And health, she believed not everyone will get the cure, not everyone will get to live, but we want to provide the most highest functional experience, optimal patient outcomes as we can for our patients regardless. And then how do other cultures perceive comfort? And what I mean by this is there's a certain part of the Hindu culture that believes that people should, I don't want to say suffer, but they believe that pain is pain and they need to manage it. It is part of the process. And that may be the older generations and not the newer generations. So other things are, what are the criteria for comfort? Right? Some people will expect to have no pain at all. Like, let's say, I always love when surgeons say to patients on their pre-op surgical visit when they're about to have surgery, and they'll say, doctor, is it going to be painful? And I love when physicians or providers say, oh, it's going to be uncomfortable, or you'll have some discomfort. They're cutting you open and ripping your guts out. I think that's going to be a little bit more uncomfortable than discomfort. Right? Some people expect to go into the surgical experience and have zero pain, and that's not a realistic outcome or a goal. We have to set the expectation, but then culturally, we may view it a certain way because of what we know or what we grew up with. And the readiness for enhanced comfort, which is, again, that person with that horrible diagnosis, or maybe you did something terrible and you're in the hospital because you got into a car accident and you feel really bad. And so that person feels like they don't deserve to be comfortable. Things like that happen. And then impaired comfort is our official NANDA nursing diagnosis for impaired comfort. And then we're going to just talk briefly about our case study. We're bringing in a little cultural. Before this, I just want to do the breakdown of the ethnic background of Lancaster County. And throughout our course, we're going to focus on the most predominant ethnic groups. The 5 most common in Lancaster County are white or non-Hispanic, 81.4%. We have Hispanics at 6.21%, Black or African American at 3.51%. And this one just says other non-Hispanic. I'm not sure what that is. I didn't describe it. 2.88%. And then Asian non-Hispanic at 2.17%. So our focus, we're going to spend a little more time on understanding the cultural influence of Hispanic patients, because we want to make sure that we're respectful. And when I walk into the room, that I don't offend them because I was unaware that I didn't follow a cultural practice to them. You can read the screen, but we're going to just talk about essentially a patient who is in early phases of diabetic clinic, or they're non-compliant. So diabetes is a very common diagnosis in the Hispanic community. Ironic is the obesity is also pretty predominant in the culture. A lot of times they manage to outlive whites when it comes to that. It's amazing. So it's just amazing how each culture expresses something slightly different. Some of the Hispanic population, so respect is a very important thing. So make sure you have a discussion with the patient on how it's acceptable to address them. Do you call them senor or senora? Or is it acceptable to use their first name to talk to them? And then another thing that is important is and it may be the older generation. I'm just going by what our text says, that the older generation, they're close talkers, meaning they don't have the personal space. Like most of us have like a 3-foot bubble around us, and we don't like people to invade our space. And now again, this was pre-pandemic. So now with the pandemic, this is a whole game changer. But before that, a lot of the Hispanic population, they don't have an understanding of that close proximity. The other part of that is they may also want to be respected and be modest about, like, let's say an assessment has to be performed and they have to undress. They may appreciate, so it'd be nice if you could offer for someone of the same sex to chaperone them during that assessment or exam or whatever it is. So again, it's just trying to think about how we can be respectful, we can deliver care to them, and we have an understanding about their pain management practices. And so try all these other holistic measures before they will even consider taking a Tylenol. Like, they have to be dying with a horrible headache to take Tylenol. And so you may notice things. So what the book talks about or describes, that they try self-care practices and they delay medical attention for things like pain management. So they may be diagnosed with cancers or other things later because they try to do all those things at home before they seek care. So just things to consider. That's all I have for today. Thanks so much for coming. It's great to have you. Have a great night.